Art really needs no introduction. I'm sure you all know him. And with that, I'm going to turn it over to Art. Thanks, Art.
Yay, Art.
Thank you. Thank you, Glenn. So this presentation is essentially a distillation of what I've figured out over the last couple of years. Bless you. People immediately get choked up as soon as I start speaking, by the way. It's like, you know, it's an emotional experience. Anyway, a distillation of what I've learned over the past couple of years in a practice focused primarily on dry eye and ocular surface disease. That's my passion. It's most of the patients I see, and I figured out a number of things that I think can be applied to most any practice, whether you're dry eye focused as a specialty or if you're dry eye focused as a subspecialty. And the reason why I think this is important is things are changing. I don't have to tell you that we have more and more challenges in optometry. We have schools that are pumping out new students all the time. And don't get me wrong, I welcome new students. You know, listen, we were all new students at one point, but frankly, we're going to have an overpopulation of ODs. I spoke to some of you about 1-800. 1-800 is trying to rewrite the rules on contact lenses to make all of them generic. And I won't even go through all the other things. If we don't take steps in our own practices to control our own fate, we're going to be in serious trouble. And this is one way of developing a subspecialty that can make a big difference for our patients and literally change the way they interact with us. We really need to reinvent ourselves, very much the same way dentists did in the 1960s and 70s when their landscape changed. And I'll talk a little bit about that at the end. And it's certainly possible. Optometry is very resilient and very capable of change. So those of you who know me know that I have one major flaw. I say exactly what I think. That could be good and that can be bad, depending on what I'm saying and what I'm thinking at the time. So these are some of the companies that have been kind enough to sponsor research in our practice or sponsor lectures that I've done or other things. Well, the shift in thinking has gone dramatically from what was just a couple of years ago, which is inflammatory as a primary driver and aqueous deficient dry eye, to meibomian gland deficiency as a driver of most dry eye. And I can tell you that in my practice, better than 90% of all patients either have meibomian gland dysfunction, have a contribution from meibomian gland dysfunction, or managing meibomian gland dysfunction and lid disease is a primary lever that I can use to change how they are. And I'm talking about patients with Sjogren's, I'm talking about patients with aqueous deficiency. Managing meibomian gland dysfunction is a major way of making a big difference in patients' lives. How do I know that? How many of you give out solutions, drops, wetting drops, sustain, refresh, all the time, over and over and over again? How many times have you prescribed Restasis and the patients come back, or maybe from another practice, and say, you know what, I used to be on Restasis, it doesn't work. And you know what? For most patients, it doesn't work. And the drops don't work either. So let's look at an understanding of what's going on behind the scenes. You really have to look at why we have systems that maintain homeostasis. You can break the systems down into really two main areas: anatomical, meibomian glands, rachimal glands, goblet cells; surface, aqueous component, and lipid layer; and sensory motor, blinking, and we'll talk about how that drives it, and lid closure. Well, let's go immediately to an examination. The very first thing we do in our practice is every time a patient comes in, we either do, and I go back and forth between the speed test and the OSDI. Why? Because I want to identify these patients in my practice. If you're not surveying patients to see if they have dry eye symptoms, you're wasting an opportunity. It's the same thing with allergy. If you don't ask if the patients have allergy, they'll never tell you because they're taking Visine for allergy or they're taking something else. If you don't identify the patients, you're not going to get anywhere. The OSDI and the speed test are really simple, elegant ways of identifying patients. This is especially important if you have a general or a primary care practice. And I'm very, very fortunate. My wife has a primary care practice with a strong focus on glaucoma and retina, and I have mostly an anterior segment practice with a very, very strong focus on dry eye. And between the two of us, we do some contact lenses, although we argue which one's going to end up doing them, but that's another story. It's a husband and wife story made in heaven. So this identifies patients. It also quantifies the patient's experience. So how many of you fit contact lenses? Don't even raise your hands. All of you fit contact lenses. And what do you do when a patient comes in? How you doing? Or if you come from Brooklyn, how you all doing? How those lenses fitting? And what is the patient going to say? Oh, I'm doing great. I feel fine. You know why? Because the patient likes you. Patient doesn't want to make you feel bad. Patient's absolutely miserable after 6 hours of wear, but you're doing just fine. You ever ask a patient on a scale of 1 to 10, how do you feel during the middle of the day? How do you feel at the end of the day? You'd be surprised what the patient will say. Well, maybe about a 6 or a 7, and at night, maybe about a 4 or a 5. And then all of a sudden now you have the ability to enter a dialogue with the patient. Gee, you seem a lot more uncomfortable than you thought you were when I asked how you doing. How you doing is a social question, and I'm doing fine is a social answer. I am lazy by nature. Now, you wouldn't know it to look at me. But I am lazy by nature. And if I can get someone else to do something for me, I'm all for it. So I am very, very lucky to have technicians who assist me. And I trust them, and I've trained them, and I rely on them. We just got really lucky. We hired a nice new technician. He's just absolutely phenomenal. So a lot of the initial exam is delegated to technicians. Why? Because that's the state of affairs in medicine today. If you're not delegating responsibility to technicians, patients are wondering what you're doing. So by delegating to technicians, I basically reestablish myself as an expert, and I also get a lot of information that I don't have to get myself. So this is an interesting picture. All of a sudden in my practice, I started to see an influx of young patients. And when I mean young patients, I'm talking about 18-year-olds to early 20s who came in with really severe dry eye. And I'm trying to figure out why I'm seeing this big influx of a population that I never saw before. Why are all these young people having these issues? And I suddenly realized that my spiel, and I'll share that spiel with you when I'm in the office, is all about the blink and the importance of the blink. And I see this picture actually when I went to visit Hoya. And Hoya's all focused on blue light. And they showed me this picture because, they want to show me, the smartphones and the iPads. And I look and I see in 2005, there's this one guy holding a flip phone. How many of you remember flip phones? Yep. Flip phones. Actually, I had one of those big phones, those big, really geeky phones. That was a real flip phone. And here we are just a few years later in 2013, and it looks like Woodstock by candlelight, except the candles are smartphones and tablets, and they're all taking pictures. And how many of your patients come in sitting there on their phone? They're constantly doing close work. What happens when they do close work? Their blink rate decreases. Without an efficient blink to propel meibum through the meibomian glands begin to malfunction, and a whole cascade of events occur. So this is an epidemic and an opportunity for optometry, and I don't want you to not understand the significance of it. It's a tremendous epidemic, and we're seeing more and more and more of it in young people. And here's that guy again with that smartphone, in case you missed it. So when we look at meibomian gland structure, we really have to look at it the same way we look at the structure of an optic nerve. And the next thing we do is meibography. Why is meibography important? Well, it's as important as looking at an optic nerve. Why is it important to look at an optic nerve? It's a way of assessing the structure and prioritizing therapy. If you see someone like this over here who has slightly high pressures, you're going to be a lot less concerned than if you see someone who walks in your office who looks like this. If you see someone who has normal meibomian glands, or reasonably normal meibomian glands, you're going to be a lot less sensitive to dealing with therapy than you are someone who has almost no meibomian glands left. So meibography is a key element of the exam. It's one of the things that we do routinely on every single dry eye patient that comes in. So here's an example of a patient who has relatively normal meibography. This happens to be an Oculus keratograph 5M. And you can see these nice meibomian glands. You can see the acini. You can see the structure of the glands here as well. You can see the glands have nice ducts that are patent. And here we begin to see some issues. You can see these meibomian glands are partially missing. You can see contraction of the meibomian glands. Now, I'm going to explain what I do with these meibography images in just a minute, but they're very, very important. So this is a patient, a young patient in their 20s who had been to a number of doctors complaining of really severe dry eye, completely non-functional. And you could see that most of her meibomian glands are missing. She's missing most of the glands down here, and these are extremely atrophied and truncated. So these are patients that have really severe problems. And here's another example of someone who's in really severe shape. And this correlates, in my experience, very, very highly with patient symptoms. And the problem is, once you see this, the patient is in serious trouble. Why is that important? Because we need to intercede earlier than later. Because once it reaches this point, and I'll explain why it does, the patient is in really serious trouble. So you can grade meibomian gland dysfunction, and we'll talk about the cycle of meibomian gland dysfunction. And this is really important because it's the primary driver of dry eye and ocular surface disease for patients. Now, the other thing that I do is a non-invasive breakup time test. Why? It's not that I don't do fluorescein breakup, but this is an image that sits on my computer. We're networked, and when I go into the room with a patient, I discuss this with the patient. And here you can see someone who has, relatively mild breakup. It's occurring starting in a little over 8 seconds, a relatively small area. Here you have a patient that has much more profound breakup. I wanted to add a couple more images. We see some patients with the images mostly red. What this is basically Placido's this, and it measures the disruption in the normal image, and it times it. It's very, very effective, both for measuring non-invasive breakup time and also for discussing with patients. And we do a couple of other things that I'm not going to get into. The patient is then brought into the exam room, and then I sort of whisk in. The door's open, and I whisk in. I'm Dr. Epstein, and I start taking a history. Tell me about your symptoms. Tell me about how you feel. Initiating a dialogue is extremely important because I'm reviewing the findings that we've already had and interacting with the patient to find out exactly what's going on. And I think that's very, very important. So I educate patients right from the get-go. Why is that important? Because education is the key to this whole thing. And I start with a simple question: why do we have tears? And what do you think most people say? Well, to keep my eyes wet. And I go, trust me, if you were an engineer and you were tasked with designing a system, you would not make it a wet system. The reason why we have tears is so we can see. And I explain that the tears create a perfectly smooth surface on an otherwise irregular surface. That's the reason why we have tears. And I tell them, think about a smooth lake reflecting imagery from mountains miles away, like a mirror. And that's the reason why we have tears. And I tell them that there's a very, very strong selection pressure for that. And the caveman who's standing on a ledge looking out, over the surround with his friend, who doesn't see the lion coming, is the one who gets eaten, and the one who runs away is the one who actually survives and reproduces. The one who can forage food from a greater distance is the one who's more likely to survive. So there's a very, very strong reason why we evolved with a very, very smooth and very, very stable tear film, and that the cornea itself is not smooth enough to provide really smooth, clear, crisp imagery. And I explain a little bit about the epithelium, and I liken it to the skin. It takes literally just a second or two, and patients get it. They can touch their skin. They say, yeah, it's not really smooth. They've all put their hand under a faucet. They know water beads up. They know that the skin is lipophilic. They know that the cornea is lipophilic. And I say, it's amazing the engineering involved here. It transforms what would repel water into something that's so attractive to water that the tears stay in place. So that's really the first element of it. And they say, well, sometimes, my eyes tear all the time. I say, the tears serve many functions. In fact, we even have a built-in eye wash station. How many times the patients go, well, I've been told I have dry eye, but my eyes are tearing all the time. I tell them that's because the surface is damaged, their eyes are irritated, so they tear to wash it away. It's a normal reaction. And I tell them that we've had a lot of changes in how we look at things, and we've gone from a relatively simplistic approach to a more complex approach. But at this point, I really look at it in a very straightforward and simple way. The tear film is a structure, very much like a house. Everyone understands a house and understands how a house is built. It has a foundation, and that foundation transforms what repels water into something that attracts water and holds it in place despite gravity. So I'm standing here, and you're sitting there, and your tears are staying in place, even though gravity should pull the tears down. And the reason why is this foundation stabilizes the tear film. And we have the equivalent of walls, and they're protective. And every time we blink, those walls compress and transform, and they snap back into a protective structure, and we have a roof just like a house does. And when a roof has a hole in it, water gets in, it damages the whole structure, the walls, and even eventually the foundation. And in the eye, when the roof has a hole in it, we lose moisture, and the entire structure collapses. And when the structure collapses, patients complain of dry eye because the surface is exposed to the air. So the concept of tears as a structure makes total sense to a patient. It's something they can relate to. Everyone lives in a house, everyone has walls, everyone sees roofs. They understand what it means. And then they start thinking about their tears as a complex structure, and it makes it easier for me to really talk about the driver. And I say the problem for the vast majority of patients, almost 90%, is there's a problem with the roof. And they go, a problem with the roof? Yes. The glands that we looked at just a moment ago, those meibomian glands, produce oils that create the roof. The roof are an evaporative barrier, and it also adds structure. And when those glands aren't producing sufficient oil, the roof is incompetent, and the entire tear structure collapses, and that's why you're so uncomfortable. And the best way to address your problem, and again, this is the vast majority of patients, the literature says 86%, I say it's more than that, is by addressing meibomian gland dysfunction. And that's exactly what I do. I follow this discussion and this initial analysis of data and interacting with them to discuss what their symptoms are and when they present with what I call a physical exam. Why do I say a physical exam? Because everyone knows what a physical exam is. They go to any primary care physician, internist, and they have a physical. So I'm physically examining them. I'm touching the patient. I'm examining them using a slit lamp. The very first thing I do is I assess the competence of meibomian gland function. And I do that using a finger, expressing the glands to see if the glands produce meibom freely. So this is a very, very simple way of assessing the severity of meibomian gland dysfunction. Why is that important? Because I know how much lipid layer thickness they already have, because I've already gotten that data. I know the state of their meibomian glands, and now I want to see what happens when they blink. Because the blink is the driver of meibomian gland function. And when they stop blinking, what happens? A cycle of decay starts. What do I mean by that? Well, the oils become thicker and they become stagnant because they're not expressed with the blink. And as they become increasingly stagnant and thicker, eventually they become more and more saturated, eventually going from this clear liquid to a cloudy liquid to a thick paste, eventually to like toothpaste. And the glands begin to shut down and the glands begin to get inflamed and reabsorbed. And you can see the various degrees of meibomian gland dysfunction, from normal clear liquid to colored liquid to semi-solid and so on. And you can see it can be quite profound. Very, very significant difference. So it's really important to assess it. If you don't have an MGE, use your fingertip. Try to express the glands. That's extremely, extremely important as part of the examination. Now, I want to underscore that just because you look at a patient with a slit lamp and you don't see red inflamed lids doesn't mean they don't have meibomian gland dysfunction. A significant percentage of patients have non-obvious or no MGD. So there's no overt inflammation, there's no telangiectatic vessels, there's not a lot of signs of it, but yet when you go to express these glands, they produce nothing. So there's ongoing meibomian gland dysfunction, which is invisible to you unless you actually look for it and assess gland function. And some of these patients are actually so advanced that they're producing this thick paste. And this, again, can be assessed by physical examination. So the physical exam continues, and I use fluorescein. Fluorescein is very, very important for a number of reasons. Number one, I can assess the competence of the surface. I can also assess breakup time, and I also use lissamine green, which is very, very important for looking at a number of structures, notably the line of marks or the mucocutaneous junction, which is on the lid margin, as well as looking at staining due to cells that have been devitalized. So after doing non-invasive breakup time and discussing it with patients and saying, hey, this confirms your symptoms, this confirms the instability of your tear film, I've actually had patients start to cry. But yet, and why? Not because of the way I deliver it, because it reinforces what they've been saying all along and have been invalidated because no one's ever really dealt with it. So I always use fluorescein. Why? Because I've always used fluorescein. I want to know what's going on. Fluorescein is a standard test, and I can cross-correlate. And frankly, the two correlate very, very highly. You're all familiar with rapid breakup time, and I count just like you do, 1 Mississippi, 2 Mississippi, and we see significant disruption to the surface. You know, we see areas that are hydrophobic. So what is breakup time? Exactly that. It's areas that are hydrophobic. Why? Because the surface has been damaged. Why? Well, the surface is damaged because the surface is exposed to the atmosphere. The cornea is natively hydrophobic. The cornea is transformed to hydrophilic by mucin, transmembrane mucins and gel-forming mucins, and it creates this beautiful water-loving surface. When the surface is so damaged that it can no longer maintain that normal architecture, we begin to see rapid breakup time. So when you're seeing this, you're seeing hydrophobicity as a sign that you have fairly severe, fairly advanced dry eye. Now, fluorescein staining is very, very important because it correlates highly with symptoms. When patients have significant conjunctival staining, they generally tend to be very symptomatic, and dry eye tends to be more advanced, to the point where you literally can have almost no viable surface whatsoever. And this is one of the patients that was referred to me that was obviously in very, very serious shape. So you can see the surface is completely in terrible, terrible trouble, but look at the lids. The lids really are the driver of this. This person has no functioning meibomian glands, so they have a totally unstable tear film, and this patient is doing very, very poorly. Lissamine green is likewise very important. In this case, you can see a very, very classical staining pattern. So I use lissamine green routinely, and if you look closely, and I apologize, it's a little blurred, you can see staining on the surface of the lid corresponding to that mucocutaneous junction, the junction between the mucous membrane of the conjunctiva and the cutaneous, the skin. So that creates a line which actually is problematic in meibomian gland dysfunction because it creates a bridge that meibome can't cross. The other thing that I always check for, and it's part of a routine dry eye exam, is I look for lid closure and apposition. So I'm checking blink. Why? Because when the patient isn't blinking completely and fully, what happens is the meibomian glands backs up, the meibomian glands begin to become stagnant, oil becomes saturated, thicker, and the glands eventually begin to downregulate and eventually atrophy. But there are a number of patients who come in who actually complain of dryness when they first wake up. So the first thing I think of is failure to have lids closing and apposing properly. Now, that's extremely important in patients who lack a typical reflex. Anyone familiar with Bell's phenomenon? So what happens is when the patient closes their eyes, the eyes should roll up and out. When the eyes don't roll up and out, the cornea is exposed. When the cornea is exposed, if the lids don't close, the cornea dries out and the patients become very, very symptomatic. So probably 6 months ago, not many, but 6 months ago, I had a Sjogren's patient who was chronically in trouble. I mean, really severe distress. Had seen a number of people, came from a cornea practice. She had a line of infiltrates across her cornea. She'd been treated with a whole bunch of things. She was on vancomycin, formulated vancomycin, and she was on Besavance, and she just was in miserable pain. And when I looked at the woman, I checked her lid closure. Her lids didn't close. Yes, she had Sjogren's syndrome, but the primary problem was that her cornea was exposed and it was decompensating, and that's how it got infected. Anyway, we dealt with that. So this is a classic example of a patient like that where they have no Bell's phenomenon, they don't have good lid closure at night, and you end up with this dense band of staining. That's a very, very important sign. So now I've gone through this whole talk. I've discussed it with the patients. I've gone through all of the findings that we've done. I've gone through non-invasive breakup time. I've talked about meibography. I say, this is like an X-ray. It's not an X-ray, but it's like an X-ray. We've assessed your meibomian glands. Your meibomian glands have issues in this way or that way. I've done the examination. I explain what I found, and now I propose a treatment, which is very, very important. I ask them if they have any questions, and then we get to the issues. And for the majority of patients, again, about 90% of the patients in my office, meibomian gland dysfunction is a driver. And by the way, those of you who know me know I'm not just saying that. It is the driver in the bulk of these patients. It is the driver. And whether you choose to believe it or not, I can tell you that we have close to 90% success rate in patients who have had horrible chronic dry eyes for years and years and years. And I get blessed and thanked literally every week. And I tell you, the practice has gone from a real pain in the rear when I dealt primarily with specialty lenses to something that I really, really enjoy because I'm making a massive difference literally every day. So I want to share with you the flow chart. I'll first address aqueous deficient dry eye. We have been trained to think aqueous deficient dry eye is the primary cause of dry eye in the majority of patients. We've not only been trained to think it, we've been brainwashed to think it. The reason why we've been brainwashed to think it is there's a lot of money behind treating aqueous deficient dry eye. So we use drops. And for many of us, that means try this drop, try that drop, with really no sense of what works because we never get enough feedback to figure it out. We all have our favorites. And by the way, I'm not negating some of the drops that do work. We try nutrition, and it does work. There's no question that it helps. We try punctal plugs. I rarely put in plugs. In fact, for every punctal plug I put in, I take out at least 9. Because they're causing irritation and problems for patients. So in these patients, maybe, but it can create a cesspool because you're diminishing tear turnover. And we use anti-inflammatories, whether it's a steroid that's pulsed, whether it's Restasis, whether it's some of the new products. And I'm not saying that they don't have a role, but what I'm saying is that this is a very, very small percentage of the patients that I deal with on a regular basis. So my treatment algorithm for patients is this. I pull out a sheet. I have a sheet with a number of checks. And I go, number 1, I'm going to give you drops. I don't know if you're going to use the drops very long. And the truth of the matter is my use of drops has decreased 50%. And I'll tell you why it's decreased 50% in a second, but it's decreased 50%. Not every dry eye patient, in fact, I'd say less than half of the dry eye patients in my practice use drops on a regular basis at this point. As bizarre as that sounds, and I think most of you know I'm not wacky, I'm relatively conventional and straightforward. But we use drops. What's my number 1 drop? Sustained balance. Why? Because it has phospholipids which adhere the non-polar lipids inherent in the product to the tear film. It's a really advanced product, the best of the bunch, and there's some others, Fresh Coat and so on. I'll talk about that. Nutrition is a mainstay for every patient. I'll talk about that in some detail. It's very, very important. It's important from a health perspective. It's important because it gives the building blocks of normal meibomian gland production, and it also is an anti-inflammatory. I use Avenova on every single patient. I happened to be at the booth, hosting an expert thing today, and someone came up and said, I only use it for blepharitis. And I go, I rarely use it for blepharitis. Not that not that I don't, but I see far more meibomian gland dysfunction patients than I do blepharitis patients. So I use it a lot. I prescribe heat masks, and we'll talk about that. And then every single patient gets blink training. We'll talk about blink training, which is really important. BlephX is used on every single patient as part of the process. And then there's a fork in the road. There's a fork in the road for patients, whether they get cold or warm expression. I'll talk about that, or lipoflow, and I'll talk about that as well. So meibomian gland dysfunction is progressive. The first thing I stress for the patient is this is not getting better. You're not going to wake up tomorrow and a miracle is going to occur and you're suddenly going to be better. You're going to get worse, it's going to progress, and it's going to be harder and harder to treat. So the sooner we get to treat this, the better off we are. And I go through exactly where they are on this scale. I talk about the structure and I talk about the function, just like I said before. You're not producing lipids. I literally get nothing on expression. That's not good. Your lipid views are nil. You have very, very low lipid layer, so it means that the structure of your tears is, the lipid layer is extremely thin. The tear film is unstable based on what we've seen, and when we look at your meibomian gland imagery, you can see that you have significant issues, so you're aware of this. Now, we have to treat meibomian glands. So meibomian gland treatment is really critical. And all of us, I don't think there's a single person in the room who has prescribed and managed these patients who hasn't used warm compresses. And I can tell you warm compresses do nothing. You might as well use ice bags. And the reason why, from the time you get it from the hot water to the patient's eye, it's cooled off. You can't elevate the temperature in the lids to the point where you do anything to the meibomian glands, and you're wasting your time. If you get the warm compresses warm enough and you do it for a long enough time, you may get a little bit of benefit, but then you start rubbing the eyes and you get into the risk of deforming collagen within, or damaging collagen within the structure, and that's problematic. And if you're doing expression, that's cold or after a warm compress, patients don't particularly like it. It's not a very, very happy time. So here's the story. One of my very good friends who I worked closely with for years at Alcon on a number of projects moves to a company called NovaBay. And I was familiar with NovaBay because they did anti-infective products. And he says, hey, I'm working with Novabay. I said, oh, good, good. I'm glad to hear that. And he says, we have this new product. And I go, oh yeah, what is it? I thought, oh, this is going to be great. It's going to be, a new anti-infective. Maybe we'll get a clinical trial out of it. Maybe it'll be really good. And I said, well, come on, what is it? And he goes, it's eyelid cleanser. And I go, what? Really? Eyelid cleanser? I mean, I'm actually not being really facetious. So he says, it's really good stuff. Let me send you some samples. And I've never been a big eyelid cleanser fan, because frankly, what happens is, and we'll talk about this in a little bit, when you have meibomian gland dysfunction, you have so much staph overpopulation and so much production of lipase that you have so much soap that the last thing you want to do is add detergent. So, and I'm thinking, this is what this is. Anyway, he sends it. My wife is a great clinician, and she's primary care, she sees a lot of patients, and this stuff is sitting on my desk, getting dust. And my friend is nice enough, he's not bugging me, and he's not pressuring me, and I don't say anything. I figure maybe it'll go away, it's like it'll disappear off the desk. My wife comes home one day and she goes, what's in that stuff? I go, what's in what stuff? I thought she was talking about me. But she said, what's in that stuff? I said, what do you mean? She said, that eyelid cleanser stuff. I go, what do you mean? She goes, I used it on a couple of blepharitis patients. It just was insane. These patients are doing so much better that it blew their minds, it blew my minds, and they were afraid they can't get enough. They're afraid that they can't order it because I only had samples. So I said, I don't know, Anyway, so I took a hint. She's a better clinician than I am, I think. And I started using it on MGD patients. And I discovered something interesting. These patients do amazingly well. In fact, not only do they do amazingly well, I've had patients who get really nervous that they won't be able to get more. They'll buy extra boxes of it. It's very, very effective. This came from a product that was designed for necrotizing fasciitis. It's pure hypochlorous acid, and neutrophils produce hypochlorous acid to kill bacteria in the body. Necrotizing fasciitis, what happens is the bacteria proliferate, they increase in population, they produce a lot of toxins and enzymes which degrade and damage skin, and basically this was designed as a lavage, which really makes a significant difference. So we use management of lid disease products for a number of different reasons, and certainly blepharitis is at the top, ocular rosacea is really high up. We do it for pre-op prophylaxis. We want to debulk bacteria. We want to reduce populations of bacteria on the lids. Contact lens wearers, have good reason to use it. I can get into that later if you want. But for meibomian gland dysfunction, staph overpopulation is a major, major issue. It's a major, major issue. And I've known this for years. I had the good fortune of working with some really good cornea people, Eric Donenfeld and Hank Perry in New York for probably about a dozen years. And this was something I discovered when I was working with them. So this is typical. You have a patient that has fairly advanced meibomian gland dysfunction. You can see this is a contact lens wearer. They're not happy. They have almost no tear film. You can see the plug glands, the telangiectatic vessels. There's enough staph bacteria on this lid to kill a horse. There is a ton of staph bacteria, and that staph bacteria hates every other staph and every other bacteria anywhere near it. It wants to kill it. So it releases toxins. Staph exotoxin produces infiltrates and causes inflammation. It's one of the reasons why the lids look so miserable, and we'll talk about managing the misery of the lids in a second. But it also produces lipase. Now, what does lipase produce? Well, lipase breaks down lipids, right? And when it breaks down lipids, it produces free fatty acids and soaps. And you've all seen frothing in the tear film. And meibomian gland dysfunction patients always say, my eyes are burning. You know why their eyes are burning? Because they all have soap in their eyes. So this is very, very effective at limiting staph bacteria and degrading these enzymes before they get into the tear film and stopping those enzymes from breaking down the lipid that's already there. So these patients are much, much more comfortable. It's not a long-term strategy by itself, but it's a miracle for patients who are miserable. and it makes a tremendous, tremendous difference. This has been one of the most important things that we've added to our practice, and it's improved a patient comfort tremendously. And neutrophils are very, white cells, you're all familiar with it. They release toxins. They're trying to be the ones that survive. They try to kill everything else in the area. Those toxins are very pro-inflammatory, and the enzymes that they produce make a very, very significant difference. And you can see that here's a neutrophil chasing a poor bacteria. Bacteria is freaking out. It's running around. It's getting cornered, it doesn't like it, and then when the neutrophil gets it in the right place, it surrounds it, and it begins to release hypochlorous acid. Hypochlorous acid begins to degrade in picoseconds, but it completely knocks out the bacteria and also eliminates both toxins and enzymes. And that's the reason why neutrophils are so effective. It doesn't damage tissue, so you can literally spray this stuff right in your eye, but it completely overwhelms the bacteria and eliminates the bacteria. It's very, 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 very effective. And as I said, this is part of a family of products, Avenova, Celorex, and Nutriphase. Very, very effective. Blink training is really important. We have a sheet for patients that don't have iPhones, and we have an app for patients that do have iPhones. And what I've done is I've gotten a QR code now on my instruction sheets so patients can just scan it in and it automatically downloads the app. Why is blink training important? Because anything I do will be to no avail unless the patient restores normal function of the blink. The blink expels meibomi from the glands and maintains normalcy, and there's some evidence that it can actually restore normal function to glands that look to be in really, really sad shape. So if they have an iPhone, I use the app, and patients are surprisingly compliant with it, especially when I explain that they're wasting time and money if they're not. So this is an entire process from start to finish. It's not any one thing. It's not even just the therapy. It's really the counseling, it's the understanding, it's the application of it, it's involving the patient in their own therapy, it's the repeat of getting the patient back for care, and it makes a really significant difference for patients. So I want to share something with you that I think is very important, and I think it has the potential for managing some of the issues that I alluded to when I first started talking. Dentists are very, very fortunate. Patients understand the importance of dental hygiene. We do absolutely nothing to reinforce the importance of ocular hygiene or lid hygiene specifically. So every single patient understands that they need to brush their teeth every morning and every night, but how many patients understand the importance of lid function and what that means to them, are willing to maintain it through nutrition, are willing to maintain it through lid hygiene, are willing to maintain it through regular visits, are willing to come back every 6 months for a cleaning or for a deep cleaning with LipiFlow? And the answer is none. You know why? Because we never even talk about it. We never say a word about what I call the dental model, and yet patients are so receptive to it. The vast majority of patients will adhere, are compliant to dental hygiene, and yet we do nothing about it, even though while we're fiddling, Rome is burning. While we're fiddling, 1-800 Contact Lenses is taking away our prescribing discretion, and an influx of ODs is taking away income and a host of other problems. So the dental model equivalent is the toothpaste and the brushing every day is Avenova and simple lid hygiene. The routine cleaning is Blefex every 6 months. This is out of pocket. This is not insurance. You're not going to get a check that's discounted by 60% and a copay that the patient's angry about or hit the patient's deductible. The patient comes back and spends this out of pocket for Blefex. If the patient needs deep cleaning, and they'll probably need it every year to year and a half, LipiFlow. The patients need imaging. They need mybography, DMI, or Oculus. They need flossing, warm, moist heat. You provide that. You provide it in your office. They need nutrition, PRNDE. You make profit from this. It supports your practice. It makes you survive whatever comes. It makes you available to patients. It increases their access to care. So it's critically important that we begin to embrace this model. All of these things come together to make a massive difference in how patients perceive us. We have to stop treating acute problems and start treating preventatively. We have to change our entire mindset the same way dentists did in the 60s and 70s. They went from filling cavities and creating dentures to oral hygiene and saving teeth and caring for gums and making patients better. And that's really what's going to transform our profession over the next couple of decades. And you're going to be hearing more and more and more about this until it's drilled in. And we have the technology. We have the Blefx. We have the Avenova. We have the LipiFlow. It's literally there. All we have to do is seize it, apply it, and be comfortable with ourselves so that we can do this. It makes a tremendous difference. This dental model can literally transform eye care. And I'm not just talking optometry, I'm talking ophthalmology too. They need to get with it as well. They may not be facing eyeglasses.com stealing their spectacles, but they're facing the same constrictions in funding, in reimbursements, and other issues.